So welcome to the class. Today's topic is guidelines on the post-exposure prophylaxis, that is PEP for varicella or shingles. This is updated in January 2023. So we begin with our quote, master MRCOG with concept-oriented clarity. This particular guideline is going to be very, very important because you will have EMQs from this particular guideline. Okay. So what are the high-risk groups? So the high-risk groups are the immunocompromised individuals, pregnant women, and neonates. Okay, so three things: immunosuppressed individuals, pregnant women, and neonates. These groups can develop severe or life-threatening varicella with complications such as pneumonitis. Okay, so what is the purpose of PEP, that is post-exposure prophylaxis, is to reduce the disease severity and the risk of complication. It is not intended to completely prevent the infection. So the post-exposure prophylaxis is not intended for prevention, complete prevention of infection, but it is meant to reduce the severity and risk of complications. So traditionally, if you see the older guideline, the medicine which was used, or the drug which was a varicella zoster immunoglobulin. Historically, it was used for PEP. Okay, but what was the problem with that? There was a national shortage of varicella zoster immunoglobulin due to manufacturing issues, and UK Health Security Agency, that is UKHSA, formerly it was called as PHE, they reviewed the alternatives. And what were the interim measures which were suggested? VZIG, that is varicella zoster immunoglobulin, reserved for the most vulnerable where antivirals were not suitable. Okay, and antiviral oral is recommended as an alternative for immunosuppressed contacts and pregnant women from 20 weeks of gestation onwards. Okay, so here comes the role of antivirals as a PEP. Okay, initially it was VZIG, but there were logistic issues, and hence it was decided that antivirals are comparable efficacy is there. So the use for immunosuppressed contacts and the pregnant women from 20 week onwards. Okay, so updated recommendation from 2023 is antivirals are recommended for PEP in all at-risk groups except susceptible neonates exposed within 1 week of delivery. Okay, either in utero or post-delivery. So just remember, antivirals are recommended for PEP in all risk groups except within 1 week of the delivery. Okay, and VZIG, varicella zoster immunoglobulin, remains the recommended only when oral antivirals are contraindicated. Okay, so next topic is a post-exposure risk assessment. Okay, does the person need PEP? This is the most important question, whether this patient requires PEP or not. So which factors we need to take into account to decide the post-exposure prophylaxis? So there are criteria for recommending post-exposure prophylaxis. The PEP is required only if all three criteria are met. Okay, significant exposure to the chickenpox, that is varicella, or shingles, that is zoster, during the infectious period. So listen this carefully. There has to be significant exposure. Okay, so this significant exposure to the chickenpox or shingles during the infectious period. So we should know the infectious period, and we should also know the infectious period for the chickenpox, and we should also know the infectious period for the shingles, and we should also know whether it is significant or not. Okay, and second is a high risk individual. Which are high risk individuals? Just now we have seen immunosuppressed neonates and the pregnant women, and no antibodies to varicella zoster virus, which is confirmed by the urgent testing within 24 hours if needed. So you carry out this antibody testing, and if the antibodies are negative, then you go ahead with the PEP. So all these three criteria, there has to be significant exposure to the varicella and or zoster during the infectious period. The person should be a high risk individual, and there should be no antibody to varicella zoster virus. Okay, so let's see about this chickenpox and shingles and their infectious period. So regarding the chickenpox, the transmission route is inhalation of the aerosols, direct contact with the vesical fluid, and respiratory secretions. And what about the infectious period? It differs for immunocompetent person and immunosuppressed person. Okay, so the infectious person period for immunocompetent person is 24 hours before the rash and 5 days after the rash. Okay, So the person is infectious 24 hours before the onset of the rash and 5 days after the rash, provided the person is immunocompetent. If the person is immunosuppressed, then he or she will be infectious 24 hours before the onset of the rash until all lesions are crusted. Okay, so these immunosuppressed patients are infectious till the crusting of all lesions, while immunocompetent persons 24 hours before the onset of the rash and 5 days after the rash. Okay, now coming to the single, okay, or zoster. So mainly transmission is mainly direct contact with the vesical fluid, and in immunosuppressed it may get transmitted via respiratory secretions also, and infectious period is from the onset of the rash until all lesions are crusted. Okay, so did you see the difference between the chickenpox and the shingles in the infectious period?
Yes, sir. One is 24 hours before the onset of rash, and zoster is since the onset of the rash.
Right. And this also differs from immunocompetent and immunosuppressed person. Okay, so it will be infectious till 5 days after the rash, and this will be till all lesions are crusted. Okay, so this is the most important thing, because they'll give you the scenario and you have to identify whether the person is immunocompetent, means index case is immunocompetent, immunosuppressed, and what kind of exposure is this. Okay, whether that exposure is in the infectious period or not. Then next, it will also depend upon the type of varicella zoster virus infection in the index case. Okay, so contact with the chickenpox, contact with disseminated shingles case, contact with immunocompetent individual with exposed shingles. Okay, read this carefully. Contact with the immunocompetent individual with the exposed shingle lesions such as ophthalmic shingles. Okay, so when you are looking at the index case, and if it is a shingles and the person is immunocompetent, then it should be in the exposed area such as ophthalmic shingles. Okay, but if the person is immunosuppressed, in that case, any localized shingles has got a viral shedding. Okay, so these are the patients cases which require a PEP. So one, with respect to the chickenpox, any contact with the chickenpox in the infectious period. With respect to shingles, if it is a disseminated shingles case, or if the index case is immunocompetent, then if the lesion is in the exposed area such as ophthalmic shingles. Okay, and if the if the contact is immunosuppressed, then individuals with localized shingles have an increased viral loading. So contact with immunocompetent individual with non-exposed shingles such as thoracolumbar lesions, PEP is not indicated. So they generally ask you this in the SBA. This SBA will be in the first 10 SBAs of your paper, especially in paper 1. That which has got a highest risk of infection. So the ophthalmic shingles, because it is in the exposed area. Okay, while thoracolumbar is a non-exposed area, the PEP is not indicated in immunocompetent person. But if it is in the immunosuppressed, then any localized shingles will be having increased viral shedding, so PEP is indicated. Is this clear to all of you? Is this clear?
Yes, sir. Yes,
yeah.
yes.
Okay, so this is going to be important. Now coming to the timing of exposure. If it is a continuous exposure with the index case, such as a household, the index case is in the household only, or nursery, or care worker, so PEP is indicated. There may be multiple exposure with the index case during the infectious period. This can happen with any case. Okay, then single exposure within the infectious period. Okay, single exposure within the infectious period, that is for, we have just seen what is the infectious period for chickenpox, that is 24 hours before the onset of the rash and 5 days after in immunocompetent person, and until lesions are crusted in immunosuppressed patients, while shingles from the onset of the rash until lesions are crusted. Okay, so in this case single exposure will also require PEP. So there may be continuous exposure, there may be multiple exposure during the infectious period, or there may be single exposure within the infectious period. Okay, now in which cases the PEP is not, if the exposure is outside the infectious period, PEP is not indicated. Now closeness and duration of the contact. Okay, suppose where it is indicated, if it is a household contact, then same small room for more than 15 minutes. Okay, in the same room, if there is a contact more than 15 minutes, this is called as significant exposure. Okay, so you have to identify whether the exposure is a significant or not. Okay, and if it is a face-to-face contact, again conversation level, that much contact, PEP is indicated. And in immunosuppressed contacts, in open wards also, the risk of airborne spread, especially in pediatrics, is known. Okay, so in all these cases the PEP is indicated. Okay, brief or casual contact, no direct or close exposure, PEP is not indicated. So what is the, if you are given a scenario, please see what is the scenarios is saying. What is the duration, where it was, what was the duration. Okay, so you identify and then you have to decide regarding the PEP. Okay, that is why I have kept a separate slide to, so that you can understand it well. Okay. Now coming to the assessment of the susceptibility, what we have seen is in which cases it is indicated, in which cases it is not indicated. But from the patient point of view, whether the candidate or that particular person is susceptible or not, that also we should be able to find out. So there is no benefit of varicella zoster immunoglobulin if the patient already has adequate antibodies. Okay, if there is IgG, VZG, IgG is positive, then there is no benefit of immunoglobulins. Okay, for immunocompetent person, including pregnant women, if there is a history of chickenpox, shingles, or 2 vaccine doses. Okay, suppose the person is in immunocompetent and already has got a history of chickenpox, shingles, or already vaccinated, then the person is not susceptible for the infection. Okay, but if there is no such history, okay, then what we have to do? We have to do the antibody testing. Okay, so this there is a history is not sure about the previous infection. What? Okay, if there is no history, then we will have to do the antibody testing on the booking sample. Okay, and post-exposure prophylaxis is required if the immunoglobulin level is less than, antibody level is less than 100 milli international unit. Okay, remember this particular figure because it is different for immunosuppressed person and it is different for women. Okay, so if there is clear-cut history, then PEP is not required. If there is no history, then we will do the antibody testing. Okay, and if the antibody testing is negative or less than 100 milli international units, so this is quantitative. Okay, if it is a qualitative negative, then also PEP is required. If it is a quantitative less than 100 milli international units, this immunoglobulin PEP is required. Okay, the person is immunosuppressed. Okay, in that particular case, reliable. Okay, always go for antibody testing. So this was for the immunocompetent, including the women. Suppressed patient, the history of infection, vaccination, always test antibody. Please unmute yourself. Okay, history of infection, vaccine, not always go for. And if the person will be said to be immune if antibody level is more than or equal to 150 international units. Okay, and if the levels are less than 150, then PEP is required. Is it clear? The levels of antibody and where the significance of the chickenpox infection, shingles,
Yes.
in immunocompetent persons, but in immunosuppressed, that is not reliable. Okay. So this is what about the assessment of the susceptibility. Then coming to the types of post-exposure prophylaxis. Now, recently in the first slide only, we have seen there are 2 types. Previously it was VZIG, okay, varicella zoster immunoglobulin. Now it has shifted to the antivirals. So first we will discuss about the antivirals. So antiviral, there are 2 antivirals, acyclovir and the valvacyclovir. Okay, first line PEP is given for 1 susceptible immunosuppressed individuals, all susceptible pregnant women, any stage, and high-risk infants. Okay, so this first line PEP is required for susceptible immunosuppressed individuals, all susceptible pregnant women, and high-risk infants. when it should be started. Okay, now listen carefully. So the start day is from 7 to 14 days after the exposure, and it is to be continued for 7 days. Okay, so when it should be started, if there is exposure, then it will be started 7 days after the exposure, and it will be continued for the 7 days. Okay, and this can be started up to 14 days of the exposure. Okay, it should be started after the 7 days, but can be started up to 14 days, and it is to be continued for the 7 days. Okay, the exposure day is the rash, onset of the rash in cases of household contact, and in cases of non-household contact, the first contact will be considered as the day of exposure. Okay, if the person is presenting after day 7, a 7 days course can still be given up to the day 14. Okay, so ideal treatment we should start at 7 days and continue for 7 days. But if the person reports, or if the lady reports after 7 days, then also this 7-day course can be given up to day 14. Okay, is it clear? The PEP?
Yes.
Yeah. Okay.
Yes, sir.
Then why it should be started at day 7? So it has been seen that starting acyclovir immediately after exposure, there is a higher infection rate, almost 77%. Okay, versus starting on day 7, the infection rate is, means in spite of giving PEP, then also infection can happen, but this infection rate was higher if it started immediately. It was less, 21%, if it started on day 7. Okay, so this is what is the difference, and that is why we should start at day 7. Okay. Just a moment. There is some issue. Okay. Yeah. Then what is the drug of choice? Acyclovir is a standard option. Okay. Valvacyclovir is preferred in some cases due to the better bioavailability and fewer dosing. Okay, and better tolerance. So you have acyclovir and valvacyclovir. The valvacyclovir is the dosing schedule is preferred. Okay. Less number of doses are required in valvacyclovir. Side effects are dizziness, headache, GI upset, nausea, vomiting, diarrhea, skin rash, pruritus, photosensitivity, urticaria, fatigue. So these are the side effects. Then what are the precautions? Renal impairment, malabsorption needs the adjustment of the doses of acyclovir, and VZIG may be considered. Okay, and VZIG only if seronegative, antibody level less than 150 in cases of immunosuppressed, or less than 100 milli international units in pregnant women. Okay, urgent cases, qualitative antibody testing is acceptable. Now, recommended oral antiviral doses are: for infants 10 milligram per kg 4 times a day. For children 10 milligram per kg, maximum is 800 milligram QID oral acyclovir. And for adults, remember 800 milligram QID 4 times 800 milligram. So this is the dose which is given for PEP. Okay, so PEP dose is different, and the dose for treatment or therapeutic dose is different. So oral acyclovir for adult, it is 800 milligram QID given for 7 days. If it is a valvacyclovir, then it is not indicated in infants. But after 2 years, it can be given in a dose of 20 milligram per kg. Maximum is 1000 TID, and for adults, it is a 1000 milligram TID. So this is only the dosing, if you see, is more convenient with the valvacyclovir. Okay. So special note is that individuals on long-term prophylaxis, such as the patients who are on hematopoietic stem cell transplant and all, they may require temporary dose escalation to the above treatment levels. Then licensing, not licensed. This drug actually not licensed for PEP, but widely used for chickenpox treatment. Okay, but off-label prescribing is allowed if it is in the patient's best interest and supported by evidence. So you need to talk to the patient and tell that this is beneficial, so can be used. Okay, so always inform the patient, then use. Repeat exposure: if the person is re-exposed, then the further antiviral PEP courses can be started 7 days after the second exposure. So if there is a second exposure, again start second dose after the 7 days. Okay. Now coming to the second PEP. So second variety is a human varicella zoster immunoglobulin. So for whom it is indicated for individuals unable to take oral antivirals, and for susceptible neonates exposed within 1 week of the delivery. Okay, so this is the thing which you should always remember. The role of VZ, previously this was the preferred. Now, because of the logistic issues, they have shifted to antiviral. But still, where is the role? One, if the person is not able to take oral antivirals, and second, up to neonates up to 1 week of activity. Then what is the preparation supply? Prepared from pooled plasma non-UK donors by Bioproducts Limited. It is supplied in 250 milligram vials. Okay, the doses is, these are the doses. Okay, below 5 years it is 250 milligrams, 6 to 10 years it is 500, for adults it is 1000. Okay, 11 to 14 is 750 milligrams. How it is given? It is given deep intramuscular injection. Divide the doses if the volume is more than 3 ml in young children or more than 5 ml in older, and neonates and infants, injection site is upper outer buttocks. Okay, what should be the timing? Ideally within 10 days of exposure, but for immunosuppressed and neonates it should be given within 7 days. Exposure day, we have already seen, it is the rash of onset in cases of household, and it is the first contact in cases of non-household. Okay, if there is a second exposure occurs beyond 7 days, or in cases of immunosuppressed within after 7 days, then we have to reassess for the need for the repeat PEP. Okay, special note is that individuals on regular IVIG, they will not require VZIG if the last dose is taken within 3 weeks of the before the exposure. So if the person for any reason is on immunoglobulin therapy, and if the last dose of immunoglobulin is given within 3 weeks, then VZIG is not required. Okay, so the VZIG, where exactly the role is, I hope it is clear to you. Okay. So what is the guidance for specific groups? There are only 2 groups. One is an immunosuppressed. Basically, there will be 3 groups: immunosuppressed group, pregnant women, and the neonates. Okay. Now, immunosuppressed individuals. All immunosuppressed individuals are at a risk of severe chickenpox and must be assessed after exposure. Efficacy: varicella zoster immunoglobulin reduces severity, but not always fully protective. Acyclovir and valacyclovir shown to be as effective as immunoglobulins. Breakthrough infections reported, but usually mild to moderate. Okay, so acyclovir has got a strong safety profile, and immunoglobulin, VZIG immunoglobulin carries low, but still the risk is present as similar to the blood product. Okay, so RCPCH guidelines says both antivirals as well as VZIG can be given, but UK now they prefer antivirals. Since 2018, they are preferring the antivirals only. If chickenpox develops in spite of PEP, if PEP is given, but still there is a chickenpox, then what to do? The prophylactic dose, you will convert it into therapeutic dose. Okay, so therapeutic dose we'll see soon. So start therapeutic antiviral dose immediately, and if it is a severe disease, admission and IV acyclovir is required. So in cases of severe disease, hospitalization and IV acyclovir. If the patient is stable, then therapeutic dose is required. Okay, which is different from the PEP dose. Okay, if there is a second exposure, reassess the patient. Repeat risk assessment, like what we have seen. What is the duration of exposure? Whether it is in the infectious period or not. Okay, that you will reassess, and then antibody recheck before further prophylaxis. If exposure follows closely after antiviral course, repeat antiviral starting 7 days post exposure. So if the exposure follows closely after the antiviral dose, we will be repeating antivirals after the 7 days. Okay, and if there is an inadvertent vaccination, if immunosuppressed patient receives live vaccine or shingles vaccine, urgent assessment is required and start antivirals if susceptible. Okay, if there is an inadvertent vaccination with a live chickenpox or shingle vaccine, urgent assessment and antivirals are to be started. Then second category is the pregnant contacts. So what is the risk in pregnancy? Suppose there is an exposure to the varicella zoster and the pregnancy is less than 20 weeks. Then there is a risk of fetal varicella syndrome. Okay, but in lateral pregnancy, what is the risk? One, there can be severe maternal infection and there can be neonatal varicella. So neonatal varicella is different and fetal varicella syndrome is different. Okay, so in late pregnancy, there is a severe maternal disease and there is the possibility of neonatal varicella if the exposure is near the delivery. So what is the rationale for PEP? It will reduce the maternal infection severity and it will reduce the fetal and neonatal infection risk. Safety, we have 2 options, VZIG and acyclovir or valacyclovir. VZIG is safe, but it will have the same risk as a blood product. Acyclovir and valacyclovir not licensed in the pregnancy, but large studies show safety, no increase in the birth defects. So efficacy of immunoglobulin is suboptimal. Around 40% will develop chickenpox. Okay, so equally effective is acyclovir, and hence it is preferred. So go for acyclovir. Okay, so it is equally effective, preferred, well tolerated, easier access. So risk assessment: if there is a history of chickenpox or shingles or 2 doses received by the mother, she is immune, no PEP is required. Okay, this also we have seen. If the history is uncertain or there is no history, what we will do? We will test for immunoglobulin. This is the SBA which is the most commonly asked. They'll give you the scenario, and if there is no history, then you will do the testing. You will find out the antibody level, okay, from the booking blood. If it is more than or equal to 100 million international, that means she is immune. Then no PEP is required. If she is less, value is less than 100, she is susceptible. Then you will treat. Okay. Then recommended PEP dose we have seen: acyclovir 800 milligram 4 times a day to be started on day 7, given for 7 days there onwards. Alternative is a valacyclovir 1000 3 times a day. Okay, same duration. And VZIG only if unable to take oral antivirals. Okay, if exposure is after the day 7, then still it can be given up to day 14. Okay. Now, if chickenpox develops during the pregnancy, then what we will do? You will switch to the therapeutic dose. And what is the therapeutic dose? 800 milligram 5 times a day, or valacyclovir 1000 milligram 3 times a day for 7 days. Okay, so here is the difference. So the PEP was 800 milligram 4 times a day, but the therapeutic dose is 800 milligram 5 times a day for 7 days. Okay, and in severe cases you will give IV acyclovir. If there is a second exposure, you will repeat the risk assessment and consider another course. Okay, inadvertent vaccination we have seen. If it is a live chickenpox or shingles, in that particular case, you will assess the immune status and monitor the mother. If it is a non-live vaccine, then there is no risk and no action is required, and report all inadvertent vaccination in pregnancy to UK Health Security Agency vaccine in pregnancy surveillance. Okay, so you need to inform to the UK Health Service security agents. Okay, same thing is given here in tabular form. High risk of immunosuppressed individuals are at high risk of severe chickenpox and complications. A routine assessment is required after significant exposure. For pregnant women less than 20 weeks, there is a risk of fetal varicella syndrome that is identified as a microcephaly, limb defects, and scarring. Okay, so these are the typical features of fetal varicella syndrome. Okay, then in later pregnancy, there is a risk of severe maternal disease and neonatal varicella if the exposure is near to the delivery. What is the recommended PEP in immunosuppressed individuals, and what is the recommended PEP in pregnant women? The first choice is oral antivirals. Here also first choice is oral antivirals. Dose is same. Okay. Then alternative is varicella zoster immunoglobulin. Here also alternative is valacyclovir can be given, or VZIG only if unable to take antivirals. Otherwise, this is the first choice. This is the alternative, and this only if these oral antivirals cannot be taken. Okay. Then what is the efficacy of PEP? VZIG reduces severity but not always protective in immunosuppressed. Antivirals at least as effective as VZIG. Breakthrough infections are mild to moderate. Here in pregnancy, VZIG is suboptimal. Almost 40% will develop chickenpox, and antivirals are as effective as VZIG, and they are preferred due to the safety and convenience. Okay. Treatment: if infection develops, you will be starting in immunosuppressed, you will be starting therapeutic antivirals immediately. In severe cases, hospitalization plus acyclovir. Same thing here in severe cases, hospitalization plus acyclovir, and switch to the therapeutic dose. And therapeutic dose we have seen it is 5 times. Okay, 800 milligram 5 times, and there it was 800 milligram 4 times as for PEP. Okay. Handling repeat exposure: reassess risk after each exposure, repeat varicella zoster antibody test if possible, and if new exposure soon after antiviral course, repeat antiviral starting 7 days post exposure. Okay. In pregnant lady also, you have to repeat risk assessment and antibody test. If second exposure soon after antiviral course, repeat antiviral from day 7 of a new exposure. Okay. And if there is inadvertent vaccination in cases of pregnancy, if it is a non-live vaccine, then there is no risk, no action is required. If it is live access, you will report to the UK Health Security Agency, assess the immune status and monitor the okay, and report all cases of inadvertent vaccination in pregnancy. Okay. Now coming to the infant and neonates, and here comes the role of VZIG, because up to 7 days VZIG is required. Okay. Now risk assessment in infants and neonates. Highest risk is to the neonates in the first week of life. These will lead to high life-threatening complications. Risk depends on the maternal antibodies, prematurity, timing of exposure, and hospitalization. No PEP is required if the newborn is after 7 days after the maternal chickenpox. If the mother is having the chickenpox, the baby is born after 7 days of the maternal infection, then there is no PEP required. Okay, so this particular duration also you need to remember, and you need to read the scenario carefully for this. Okay, and if there is a maternal shingles before or after delivery, the antibodies are protective, because the mother, this shingles is a reactivation of the primary infection in the mother. So if it is a maternal shingles either before or after delivery, then PEP is not required. But if the mother has a chicken pox and the baby is delivered within 7 days, then the PEP will be required. But if it is developed after 7 days, chicken pox, then PEP is not required, because the antibodies will be protective in that particular case. So PEP indications, they are divided into 3 groups. Okay, group 1 are the neonates of mothers with chicken pox, not shingles. Okay, 7 days before and 7 days after the delivery. Okay, so these are the neonates born to the mother with chicken pox and deliver 7 days before or 7 days after the delivery. So action is to give VZIG within 7 days. Okay, so it is within 7 days the baby is delivered. Okay, within plus minus 7 days of chickenpox the baby is delivered. So here in these cases VZIG immunoglobulin is required. Okay, if maternal infection is 4 days before and 2 days after the delivery, then add a IV acyclovir 10 milligram per kg 3 times a day, 10 days. Okay, due to the highest fetal risk. Okay, is this group 1 clear to you? Here there is a maternal chickenpox infection, but the delivery is within 7 days. Okay, so
Yes, sir.
is required is a varicella zoster immunoglobulin. Okay, but if it is within 4 days before or 2 days after the delivery, then IV acyclovir is to be added along with this. Okay. Then coming to the group 2. Group 2 are the infants less than 1 year who are born before 28 weeks or less than 1000 gram at birth, or there is a severe congenital or underlying illness needing the prolonged care. So they may give you the scenario that the baby is born preterm and the baby is in the hospital in the NICU, and the mother has developed infection or something like that, and then we need the infant PEP. Okay, so action here is a test infant varicella zoster antibody. So group 1, what we did, it was directly we have given the immunoglobulin. Okay, here you will test it. If the infant is more than 4 weeks old, then we will give oral acyclovir. Okay, as usual, will be started 7 days after the exposure and will be continued for 7 days. Okay, provided the infant is 4 weeks, more than 4 weeks. If the infant is less than 4 weeks old and the antibody is negative, in that particular case, immunoglobulins are preferred. Okay, so for group 2, we have 2 options: antiviral and varicella zoster immunoglobulin. If the infant is more than 4 weeks, go for acyclovir. If it is less than 4 weeks, the antibody is negative, go for varicella zoster immunoglobulin. So here action is test infant varicella zoster antibody. Okay, so what is the action in group 2? Test infant varicella zoster antibody, depending upon then weeks of after the delivery or the age, we are going to decide either oral acyclovir or the VZIG. Then group 3 are the neonates which are exposed to the chickenpox or shingles, but not from the mother. They are exposed. So here the maternal antibodies will not be protective. We do not know about the mother. There is exposure from the outside in the first 7 days of life. Then in that particular case, what we have to do, we have to test the mother. Preferred is a mother. Other alternative is the infant antibody. Okay, and if the antibody is negative, then varicella zoster immunoglobulin is to be given. Is this clear? Group 3 is clear to you? If the baby is exposed, there is a difference between the group 1 and group 2. Both are within 7 days. Here there is a infection from the outside, not from the mother. Okay. In that particular case, we will test the mother or the infant for the antibody. If the antibody is negative, then we will give the varicella zoster immunoglobulin. Okay.
Excuse me, sir. So previously for pregnant women, the cutoff value for antibody was taken as 100. Here it is mentioned as 150.
Yes. Here they have given 150. So, and there it was a 100.
100.
And here we are talking about the, see, here this antibody level is going to be the passive protection for the baby, no?
Okay, so for babies, we are considering 150.
Here, no. This antibody is a maternal antibody only.
Okay.
Or the infant antibody also they have, but preferred is a maternal antibody. You got it?
Yes, sir.
Because baby will be protected passively, no?
Yes, sir.
So this you have to remember. Here it is a 150 international units, okay, milli international units. Then you will give varicella zoster immunoglobulin. Okay. The next is determining the immune status. So group 2 infants may lack maternal. These are premature infants, so they may lack maternal antibodies because of prematurity, transfusions, etc. So we have to test the infant. So in group 2, always test the infant. Okay. In group 2, always test the infant. Okay. In group 3, preferred is a mother. Okay. In group 3 infants, if the mother has a definitive chickenpox or shingle, no testing is required. Okay. If mother is vaccinated or uncertain history, then the test mother or the infant, and the cutoff is less than 150 international units. It is susceptible and give immunoglobulin. Okay. So in group 3, if the mother definitely has a chickenpox or shingles, then testing is not required. Is it clear? Here they are saying that test the mother, but when there is a mother is vaccinated or uncertain history, then the test mother or the infant. But if there is a definite history, you don't need a testing. Okay, and these are the cutoffs. Okay. Special note is discharge. Sometimes this scenario they can ask you. Okay, the mother is delivery, everything is fine and all. There is a discharge. She is due for the discharge today, but the elder kid is having the chickenpox at home. Okay, then discharge home is safe if the mother is immune, even if household cases exist. Okay, but if the mother is susceptible, avoid contact until the neonate is more than 7 days old. Okay. So if the mother is immune, in that particular case, the mother can be discharged. The option will be many options. They'll do not discharge for 7 days or whatever it is. But if the mother is immune, then she can be discharged. Okay. Repeat risk assessment needed for group 2 infants with subsequent exposure in the hospital, and treatment if chickenpox develops. So this is the treatment. If in spite of all this, if the neonate develops chickenpox, then the dose is 20 milligram per kg IV or cyclovir every 8 hours for 7 days. Okay. So this is the for the neonates. Okay. That finishes the first topic of varicella zoster. BHIVA Guideline. Okay. British HIV Association Guideline for the management of HIV in pregnancy and postpartum 2018. So 2019 second interim update we are going to discuss. So we begin with our quote, master MRCOG with concept oriented clarity. Okay. So we know that HIV, that is human immunodeficiency virus, it is a retrovirus that primarily infects CD4 T lymphocytes, leading to progressive immune suppression. It is transmitted via blood, sexual contact, or vertical transmission, mother to child infection during the pregnancy, delivery, or breastfeeding. HIV uses the enzyme reverse transcriptase to convert viral RNA into DNA. It will integrate into the host genome via integrase and produces new virions with the help of protease. Okay, so these are different things which you should remember. There is a reverse transcriptase, there is an integrase, and there is a protease, and the drugs are acting on this. So we need to know about it. Okay, Without treatment, HIV infection progresses to acquired immunodeficiency syndrome, that is AIDS, characterized by the opportunistic infection and malignancies. BHIVA guideline provide evidence-based recommendation for choice, timing, and monitoring of ART in pregnancy, understanding drug classes, mechanisms, safety profiles, and pregnancy-specific consideration is important from our examination point of view. Okay, so listen to these drug classes, what is their mechanism in the subsequent slides, and then we'll go for the various regimes. Okay, so coming to the various drugs which are used, the drug classes are NRTIs, NNRTIs, then PIs, and INSTIs, also called as integrase inhibitor. These are main four. Others are also there in the subsequent slide. We'll go into the details later on. So coming to the NRTIs, that is nucleoside or nucleotide reverse transcriptase inhibitors. Okay, in which we have zidovudine, lamivudine, that is 3-TC, then abacavir, tenofovir, then imicitrabine. Okay, so these are NRTIs, reverse transcriptase inhibitors, nucleoside or non-nucleoside reverse transcriptase inhibitor. What is the mechanism of action? They are analogous of natural nucleosides or nucleotides. They get incorporated into the viral DNA by reverse transcriptase and cause chain termination. They will block elongation. Okay. Then coming to the second category, NNRTI. Okay. So non-nucleoside reverse transcriptase inhibitors. The examples are efavirenz, nevirapine, rilvegostomig, then itravirin. So these are the NNRTIs. Okay, how do they act? They bind directly to the reverse transcriptase enzyme, allostatic site, cause conformational change, and inhibit the enzyme activity. So no DNA synthesis. So these NNRTIs will bind to the reverse transcriptase enzyme. Okay, they will cause conformational change and inhibit the enzymatic activity. Then coming to the PIs, that is protease inhibitor. These are lopinavir, ritonavir, atazanavir, darunavir, and indinavir. Okay, so remember these protease inhibitors are navirs. All navirs are protease inhibitors. Okay, lopinavir, ritonavir. So all navirs are protease inhibitors. How do they act? They will inhibit the HIV protease enzyme, will prevent cleavage of viral polyproteins, and leading to immature or non-infectious viral particles are formed. Okay, so they will act on the protease enzyme, and all navirs are protease inhibitors. Then coming to the integrase strand transfers inhibitors, that is INSTIs. Okay, also called as integrase inhibitors. All integrase inhibitors, integrase, here comes G. Okay, so all gravirs are integrase inhibitors. Okay, gravir integrase inhibitors. So you have raltegravir, dolutegravir, elbitagravir, then bictegravir. Okay, so these are integrase inhibitors. They will block the integrase enzyme, will prevent integration of viral DNA into the host genome. Okay, so these are the mechanism of action. Please go through all these drugs later on. Okay. Then other drugs, other classes are entry or fusion inhibitors, in which you have enfuritide and maraviroc. Okay, so enfuritide is a T20 fusion inhibitor, and maraviroc is a CCR5 antagonist. Okay, this enfuritide binds to the GP41 on viral envelope. It will block fusion with the host cell membrane, and maraviroc blocks the CCR5 receptor on the host CD4 cells and prevent HIV entry. Okay, and then you have post-attachment inhibitor, that is a monoclonal antibody emalizumab. It binds to the CD4 receptor after HIV attaches and prevents conformational change needed for entry. Then attachment inhibitors, fostemsavir, so it will bind to the GP120, prevents attachment of HIV to CD4 receptors. But at least previous slide drugs you should know, these are not frequently used. Okay, then exam tip, always mention MDT care and psychological support in management. Depression screening is done at 3 points. Okay, booking 4 to 6 weeks postpartum and 3 to 4 months postpartum. Okay, and second, sexual health screening and BASH guideline based treatment are key audit standards. Coming to the psychosocial care for women living with HIV. Psychosocial issues around HIV and pregnancy are known. Okay, antenatal HIV care should be delivered by a multidisciplinary team and offer peer support to pregnant women living with HIV where available. Okay, and perinatal health assessment, just now we have seen 3 times you have to do. One is at booking visit, screening for antenatal postnatal depression. One is at booking visit. Second is 4 to 6 weeks postpartum, and third is 3 to 4 months postpartum. So these are the time at which you will do the screening. Okay. Now coming to the screening and monitoring of pregnant women with HIV. Sexual health screening. If the lady is newly diagnosed with HIV in pregnancy, you will offer full sexual health screening. That means you have to screen for other sexual infections also, other STIs also she will be screened, provided she is newly diagnosed with HIV during the pregnancy. If the lady is already diagnosed and she becomes pregnant, in that particular case, sexual health screening is suggested. Here it is offered or recommended. Here it is suggested. Okay. And then treat genital tract infection as per the BHIVA guidelines. Lab monitoring, no extra baseline test in a newly diagnosed pregnant women beyond standard antenatal and HIV care. So whatever the tests which are required for the HIV care, only those tests and routine antenatal tests are required, nothing more than that. Then how many times you will do the resistance testing? How many times you will do the CD4 monitoring? How many times you will do the viral load monitoring? This is all you should know. Resistance testing is done before ART initiation, except in patients who are presenting late. That is, they are presenting after 28 weeks. Then the resistance testing is not done. But early trimester you are starting, then do the this resistance testing. Repeat if ART is stopped after delivery to detect missed mutation. So if it will be repeated, this resistance testing will be repeated if she stops after the delivery. Then CD4 monitoring. How many times you will do? If she is on CRT before conception, she is already known case of HIV and she becomes pregnant, baseline and delivery. 2 times you have to do the CD4 monitoring, baseline and delivery. And even if the ART started during the pregnancy, then also you have to do 2 times, baseline and delivery. Okay. Even if the CD4 count is quite good. Okay. Then viral load monitoring. How many times you have to do? One, first thing you will start combine ART. Then 2 to 4 weeks after starting the CART, you will do the viral load monitoring. Then you will carry out once in each trimester, and at 36 weeks and delivery you will carry out. So 3 times you have to do, 2 to 4 weeks after starting the treatment. Then you will repeat in each trimester. So this is already done in the first trimester. Then you will repeat in each trimester. The final is at 36 weeks. Okay. LFT is baseline at CART initiation. With each routine blood test, you will be carrying out LFTs. Okay. If viral load is not suppressed, so what is the purpose of starting this CART or this combined ART is to suppress the viral load less than 50 copies per ml. Okay. Now, if the viral load, so you have repeated this viral load 2 to 4 weeks, and you find that this viral load is not suppressed, then you have to review the adherence and drug interactions, perform resistance test, and consider therapeutic drug monitoring and optimize or intensify regime. Okay, so these are the things which you will carry out. Then what is the choice of third agent in combined ART? Preferred is efavirenz or atazanavir. That is the most safety data. Alternatives are rilpivirine, raltegravir, and darunavir. Okay. So gravirs are integrase inhibitors. Okay. And navirs are protease inhibitors. Okay. Darunavir uses 600 milligram BD if resistance or if started in the pregnancy. Okay. Dolutegravir not to be used before 6 weeks. It can be used after 6 weeks. This is a SBA. Okay. Dolutegravir, what does it cause if used before 6 weeks? Just find it out. I think it is a neural tube defect, most probably. Okay. It is not recommended. Then which drugs are not recommended? Zidovudine monotherapy is not indicated. So this monotherapy can be used only when the viral load is less than 10,000 and the patient is for elective LSCS. Otherwise, zidovudine monotherapy, always a CART, that is combined ART is used. Okay, monotherapy is not preferred. It is used except in conditions where the viral load is less than 10,000 and a patient is for elective LSCS. Okay. Then PI monotherapy, TF, darunavir, Cobis, these are not preferred combinations. Okay. integrase inhibitor based regimen, consider if viral load is very high, more than 1 lakh, or there is a failure of CART. In that particular case, integrase inhibitor, that is, they will have gravirs with them. Okay, so these integrase inhibitors will be preferred if there is a viral load high, more than 1 lakh. Okay. Now, if the lady is presenting late, woman not on treatment, we have already seen that resistance testing is not required if she is presenting late. But what we will do if she is presenting late, then after 28 weeks, we will start CART immediately. If the viral load is unknown or more than 1 lakh, use 3 or 4 drug regimen and always go for integrase inhibitor, that is gravir. Okay, and the dose is 400 milligram BD or dolutegravir 50 milligram OD. Okay, so this also you should remember. They may give you the scenario, she is late booker. Okay, she is booking late after 28 weeks. So your action will be start CART immediately. If the viral load is more than, then go for 3 or 4 drug regimen, one of which has to be integrase inhibitor. If you are using raltegravir, then 400 BD, and or if you are using dolutegravir, then 450 milligram OD. Obviously, dolutegravir cannot be used in early 6 weeks, and she is presenting at 28 weeks, so dolutegravir can be used. Okay, at 28 weeks. Then untreated women presenting in labor. Now you have a scenario in which the patient is not on CART and she comes to you in labor. Then what you will do? You will give nevirapine 200 milligram stat, that is NNRTI. Then you will give NRTI, that is 2 drugs from NRTI, 1 drug from NRTI. So 2 drugs are zidovudine 300 milligram and lamivudine 150 milligram BD, and raltegravir, that is integrase inhibitor 400 BD, and also you will give IV zidovudine throughout the labor. Okay, so here again 4 drug. Okay, 2 NRTIs, 1 NRTI, and 1 integrase inhibitor. Is it clear to you? Is it clear?
Yes, sir.
You may get confused little with the doses and all, but don't get confused with the doses. Just remember the drug, names of the drug. Okay. At least you will come to know, if you remember this way, 2 NRTIs, 1 NNRTI, and 1 protease, 1 this integrase inhibitor is required, along with IV zidovudine throughout the labor. Okay. Then if she is a preterm labor, the infant is unlikely to tolerate oral medicine, so add double dose tenofovir DF. Okay, so these patients require tenofovir in preterm labor. Okay. Unknown HIV status in labor, SROM or urgent delivery, perform urgent HIV test. If she is reactive or positive, start interventions immediately. Don't wait for the final confirmation. Okay, so when the lady comes with HIV status unknown, urgent, because this will be the point of care test. So if your point of care test is positive, don't wait for the you start with the intervention. Okay, this is what the guideline says. Then pharmacokinetics for ART in pregnancy. No routine dose changes except raltegravir is converted 400 milligram BD. Otherwise, raltegravir in a non-pregnant status, I think it is OD, but in pregnancy it requires 400 BD. Okay, and tenofovir will require TDM monitoring. Only these are the only 2 things which you should remember. Okay. If off-license dosing, if suppose she is not on a standard regimen, then you will shift her to the standard dose or do regular therapeutic drug monitoring. Stopping of the ART postpartum is not advised. Whether she is started before pregnancy or during the pregnancy, ART is to be continued throughout. Okay, even after delivery. So stopping is not recommended. If woman wishes to stop, provide counseling and follow BHIVA audit ART guidelines. HIV and HBV co-infections. Now next category. Up till now we have just seen the lady with the HIV and different situations. Like she was not in ART, coming in labor. Okay. Now the situation is she is HIV and associated with hepatitis B virus infection. Then how to deal with that scenario? Suppose if it is a new hepatitis B virus infection, recent diagnosis, we will confirm it with HBV DNA. Also other HB antigen will be done. Then other viral markers also we have to do. Hepatitis A, hepatitis C, hepatitis D you have to screen. LFTs you have to do, and look for the fibrosis, how much fibrosis is there or liver damage is there. Okay, LFTs you will check at 2 and 4 weeks after ART start, and then monitor regularly. Okay. If the pregnant on dual active, suppose she is already hepatitis B positive, okay, she is already on ART before pregnancy for both, then we will continue the same treatment. Okay, here just remember, in hepatitis B, the drug of choice here is a tenofovir plus imicitrabine or lamivudine as NRTI backbone. Here tenofovir has come. Okay, if TDF is not included, add it. So tenofovir is preferred if the patient is a infected with hepatitis B virus. Okay. Now, further thing is that if 3TC, lamivudine or FTC resistance, then TDF can be used. That is why I said tenofovir is the one of the hepatitis B. Remember tenofovir. Okay. Do not use lamivudine plus imicitrabine alone. It has got a high risk of resistance. Imicitrabine is preferred over lamivudine. Okay. Better antiviral effect. Then you will also, if she is negative for there is no hepatitis infection, then you will go for vaccination. If she is not immune, vaccinate either 2 doses or 3 doses. 2 doses are 0 and 6 months, and if her CD4 count is less than 300, then she will require 3 doses of hepatitis A vaccine, that is 0 month, 1 month and 6 months. Okay, so hepatitis B patient is to be screened for other viral infections also, like hepatitis A, C and E also. Okay, and if she is not immune, then we'll give hepatitis A vaccination, either 2 doses or 3 doses. Okay, 3 doses will be given if the CD4 count is less than 300. Okay, and continue dual active ART postpartum also. Postpartum hepatitis flares managed conservatively with monitoring. And as far as mode of delivery is concerned, if your HIV viral load is suppressed, then vaginal delivery is acceptable irrespective of the hepatitis B virus load. Hepatitis B viral load does not affect the mode of delivery. Remember, what affects the mode of delivery is the HIV viral load. Okay. Any idea how this HIV viral load will affect the delivery? Can anyone tell me if anyone knows? Any idea? Dr. Sinchana, any idea about the viral load?
No, sir.
Okay, so if you have co-infection, disregard the viral load, concentrate on the HIV viral load. Okay, and if the she is fully suppressed, then the vaginal delivery is acceptable. Okay. For neonates, what you will do, what we do routinely, hepatitis B vaccine plus immunoglobulin within 24 hours of the birth. Okay, the same thing is for the neonate. Don't forget the neonate. Okay, sometimes they will ask you the management, and you will if you have an option with the neonate, then select the option with the neonate, because that will form the complete so treatment for the mother as well as baby. Okay. Now, hepatitis B we have finished. Now, third is a hepatitis C virus. If there is a HIV and hepatitis C virus infection, in hepatitis B, which drug we have seen? Tenofovir. Okay, now let us see what is there in HCV. Now, suppose if she is a case of new HCV diagnosis, then we will confirm as usual with the HCV RNA, genotype, assess for fibrosis, LFTs and other liver disease. LFTs will be repeated 2 to 4 weeks after ART starting, and then we will monitor regularly. Here, the ribavirin-based DAs are contraindicated in pregnancy. Stop immediately if the woman becomes pregnant. So, if she is already a case of HCV and she is receiving ribavirin, that will be stopped. Okay. Women planning the pregnancy expedite DAA-based HCV therapy before conception, and HB vaccination is recommended if not immune after first trimester. So, in hepatitis C virus, we are also going to screen for B and A also. And if she is negative for B, we will, after first trimester, the hepatitis B vaccination can be given. Same like hepatitis for hepatitis A virus in vaccination, 2-dose schedule, 3-dose schedule, 2-dose schedule routinely given. If the CD4 count is less than 300, go for 3-dose schedule. Mode of delivery, same. Vaginal delivery is acceptable provided she is on antiretroviral drug and there is a full viral suppression, and disregard the viral load of the HCV here. Okay. Postpartum continuous ART in all women with HIV and HCV, irrespective of the HCV status. Okay. And coming to the obstetric management. Okay. Now, what we have seen up till now, was the lady with the HIV infection. Then we have seen co-infection with hepatitis B. Then we have seen co-infection with hepatitis C. Now coming to the obstetric management for a patient with who is on ART. Okay, combined ART. Antenatal care, routine fetal ultrasound as per national guidelines. Then you will do the combined screening plus NIPT as usual. Then invasive testing. If this patient requires invasive testing, avoid until HIV status is known. Ideally defer until viral loads is less than 50 copies per ml. Remember this particular figure. This is a key figure. Less viral load less than 50 copies per ml. This can be SBA or EMQ, that they are asking that the particular patient requires invasive testing, either amniocentesis or cordocentesis or CVS, etc., etc. And she is not screened, then first you get the HIV testing done. Okay, if she is negative, no issue. Okay, but if she is positive, then you have to start treatment, find out the viral load. Once the viral load is less than 50, then you will carry out the invasive testing. By any chance, if it is urgent and you cannot wait for the invasive testing and she is not on CRT, then start CART immediately. Include raltegravir, okay, plus single nevirapine dose, and 2 to 4 hours pre-procedure you have to give. Okay, so you will start CART therapy, which includes raltegravir. You will also give single dose nevirapine 2 to 4 hours prior to the procedure. Okay, then if the viral load is less than 50, she can also undergo ECD. Okay, so once the viral load is fully suppressed or less than 50, then vaginal delivery is also possible, ECV is also possible. She can also undergo invasive testing. Is it clear? This viral load is going to be a key figure. Okay, now coming to the mode of delivery in patients who are on CAR. Decide delivery mode based on viral load at 36 weeks. Okay, this viral load at 36 weeks will decide the mode of delivery. Viral load less than 50 copies per ml, she can be up for planned vaginal delivery. Okay, so vaginal delivery is an option if the viral load is less than 50 copies per ml. If the viral load is between 50, remember they give you exact 50. The 50 is here, less than 50 is here. So vaginal delivery is for 49, not for 50. Okay, viral load is 50 to 399 copies. Consider PLCS, that is pre-labor cesarean section. Here it is a consider PLCS, and it will depend upon the viral load, train, treatment duration, adherence, obstetric factors, and women's views. So multiple factors you will take into account, and you will consider PLCS or the pre-labor cesarean section. And if the viral load is 400 or more, directly go for PLCS. Is it clear?
Yes, sir.
Mode of delivery. Okay, here it is consider PLCS considering various factors. Here it is recommend PLCS. If vaginal delivery is planned and the labor starts, she will be managed like any low risk patient, like any HIV negative, except under cases of rupture of membrane. Okay, VBAC is allowed if the viral load is less than 50. So they can combine your VBAC guideline along with this particular guideline, and they will expect a combination of both. Whether this patient who is HIV positive, she has received so many treatment, and now she wants VBAC. Okay, so VBAC is allowed if the viral load is less than 50 copies per ml. Now cesarean section. Suppose for cesarean section is performed for HIV prevention, then it is to be performed at 38 to 39 weeks of gestation. This is also a SBA. What is the gestation at which cesarean section is carried out for HIV prevention? It is for 30. It is carried out at 38 to 39 weeks. And if it is done for cesarean section for obstetric reasons, when with viral load less than 50, okay, viral load less than 50, vaginal delivery option is available. But for any other obstetric reason, suppose there is a CPD or any other reason, there is a in spite of this you are carrying out, then it should be done at 39 weeks of gestation. So remember, for what is the indication of cesarean section, that will decide the gestational age at which it is to be carried out. Is it clear to you this timing 38 to 39 when it is
Yeah.
for HIV prevention. And if it is done for obstetric, then it is for 39. It is done at 39 weeks. Okay. Now coming to the SROM, if there is a spontaneous rupture of membrane. Okay. If it is a term SROM, AM delivery within 24 hours. Patient should be delivered within 24 hours. Now we know if the viral load is suppressed, she can go undergo delivery. But in that particular case, we are not going to wait for spontaneous onset. How many patients will go in spontaneous labor within 24 hours of SROM? Yes, Dr. Sinchana?
60%.
60%. But here you will induce augment immediately and deliver the lady within 24 hours. And if there is a pyrexia, you will treat. Okay. If viral load is between 50 to 39, 399, recommend immediate CS. Consider viral trend, adherence, obstetric factors, but recommend LSCS. Okay. In cases of SROM. If the viral load is more than 400, immediate CS is recommended. Now, if it is a preterm SROM, but more than 34 weeks of gestation, that manage this as a term SROM, but add GBS prophylaxis. Okay. So if it is a SROM after 34 weeks of gestation, then manage this as a means you will go for induction or augmentation of the labor. Okay. Provided the viral load is this. She will fit into this category or she will fit depending upon the viral load. So you will carry out same as this, but you will add GBS prophylaxis. If it is a preterm SROM less than 34 weeks, because prematurity here prevails. So what is there? Give steroids, optimize ART if the viral load is not controlled. Okay, so here the conservative management is followed before 34 weeks of gestation, and multidisciplinary discussion on timing and mode of delivery will be done. Is it clear? SRM before 34 weeks, what the guideline says? Give steroids, optimize ART, carry out multidisciplinary discussion for timing and mode of the delivery. Okay. So here they are taking care of the prematurity. After 34 weeks, it will be considered management will be same as a term SROM. Okay. Now intrapartum zidovudine. Which patients require this? Also you should know. Intrapartum IV zidovudine recommended if viral load is more than 1000 and she is presenting in labor or SROM or she is for planned cesarean section. So when your viral load is more than 1000 and she comes in labor or there is SRM, you will give intrapartum zidovudine. Okay. And we have also seen intrapartum zidovudine when it is given when she is not on CART. At that time we have given 4 drugs and one of them was IV zidovudine. Okay. Okay. Then untreated in labor and SRM with unknown viral load. And third is consider when viral load is between 50 and 1000 despite CART. So these patients require IV zidovudine. When viral load is more than 1000, when she is untreated and presenting in labor, or there is SRM with unknown viral load, or we will consider if it is between 50 and 1000. Okay. Then place of birth, there has to be associated pediatric care. Water birth, there is a limited safety data, but may be supported if the viral load is less than 50. Okay. Now coming to the postpartum management of these patients. Okay. Antiretroviral therapy, you will continue. CART is continued post-delivery. Support services, assess needs postpartum and refer to trust, community, voluntary services, postnatal depression, mental health. You are going to check for this patient. There will be multidisciplinary management. Okay. Contraception will be discussed. ART may be changed to suit contraceptive choice. Cervical cytology, schedule 3 months post-delivery as per NHS guideline. Partner and child testing. For newly diagnosed women, test partner and older children also. There are no SBs here on this slide. Okay. Yes, from here onward, the important topic starts from ESB and EMQ, especially EMQ point of view. Okay. Infant PEP. Okay. They have divided these infants into 3 categories. Okay. First category is a very low risk category, which requires 2 weeks of zidovudine monotherapy. Remember, for infant, the monotherapy is considered, but for mother, monotherapy is not indicated except where she is for elective LSCS and the viral load is once we have seen more than 10,000 or something like that. But for infant, if the infant is a very low risk, then 2 weeks of zidovudine monotherapy is given to the infant. Okay, this is the infant PEP. Now, which are the very low babies? where the mother is on card therapy for more than 10 weeks. There are 2 viral loads which are done at 4 weeks apart and the value is less than 50. And last viral load which is done at 36 weeks is less than 50. So if all 3 criteria are satisfied, then we consider that this baby is a very low risk baby and we give only 2 weeks of zidovudine monotherapy to the baby. So mother should have received card for more than 10 weeks throughout the antenatal period. There should be 2 viral loads which are done at 4 weeks apart and it should be less than 50, and viral load at 36 weeks should be less than 50 to consider this baby as a very low risk baby. Okay. Now, second category is a low risk baby. This low risk baby will require zidovudine monotherapy, but it is for 4 weeks. Okay. Now, which are these low risk babies? Here, maternal viral load is less than 50 at 36 weeks of gestation, but all 3 criteria are not satisfied. I hope this is clear. When all 3 criteria are satisfied, the baby becomes very low risk. All 3 criteria are not satisfied, but the last criteria that at the time of delivery, after 36 weeks, whatever is the viral load, that is less than 50, but not all criteria are met. Or if it is a preterm less than 34 weeks with maternal viral load less than 50, then the 4 weeks of zidovudine monotherapy is given. But if it is a high risk, that means viral load is not less than 50, then you have to give combination PEP if maternal viral load is more than 50 at birth, or if it is unknown viral load, or if there are adherence concerned about from the mother, then PEP is given started within 4 hours of the birth, and it is a combined drugs, not the monotherapy. Okay. Now, if the mother is having resistance, if there is a resistance in that particular case, still zidovudine monotherapy is given to the baby. Okay, very low and low risk. In here we are giving zidovudine monotherapy, and there are resistance to the zidovudine in the mother, but still for the baby you give very low or low risk category zidovudine. Is it clear to you? In spite of maternal indicated for the baby, provided the baby is either low risk or very low risk. Okay. Now you have got a for high risk with resistance. Okay. But if the baby is high risk and there is a resistance to the maternal resistance is there, then what is recommended? You have to give zidovudine, lamivudine, nevirapine. And if it is HIV2, in that particular case, use zidovudine, lamivudine, and raltegravir until advice. Okay. So very low and low risk, you will give monotherapy. But if it is a high risk with maternal resistance, it is a this zidovudine, lamivudine, nevirapine for HIV1, and for HIV2, zidovudine, lamivudine, raltegravir. Okay. And do not extend more than 4 weeks, even if she is breastfeeding. This infant PEP is not indicated for more than 4 weeks. Okay. In all groups, maximum it is given for 4 weeks. Here also 2 weeks, but monotherapy. Here 4 weeks, but monotherapy. Here also it is 4 weeks, but the combination PEP. Is it clear now? Very low risk and high risk?
Yes, sir.
Yeah. Questions are asked here. That particular slide is going to be very important. Then what is the timing of starting pneumocystic carina pneumonia prophylaxis to the neonates? This is started at 1 month. Okay. If the infant HIV PCR is positive or confirmed HIV, stop only if HIV is excluded. So cotrimoxazole from 1 month will be started as a PCP prophylaxis. Immunization, follow the national immunization schedule. Rotavirus not contraindicated unless severe immunosuppression. BCG at birth, if it is a very low risk or low risk, it should not be delayed. Okay, BCG will be given for very low risk and low risk baby. Now coming to the infant feeding. In UK, they follow the top feed. Okay, so formula feeding is recommended. No HIV exposure after birth. Support needed for women, psychological, financial, free formula should be provided. So lactation suppression with cabergoline, if not breastfeeding or if maternal viral load is more than 50. Okay, so preferred is a formula feeding. Now breastfeeding options. Breastfeeding may be allowed if viral load is less than 50. There is a good adherence and risk of transmission is low. Requires monthly maternal and infant viral load monitoring during and 2 months post weaning. and maternal cart, not the infant PRP, protects both mother and infant. Okay, so mother should be on cart. That will protect both mother and the infant, even if she is breastfeeding. Okay, but that is for a viral load less than 50. Now this is the last slide, I guess. This slide is also asked. Okay, when will you test the baby? Okay, how is the screening of the baby is carried out post delivery for HIV? Okay, now we have two categories. One is a non-breastfed infants and other is a breastfed infants. Okay, so for non-breastfed infants, most of the babies will be non-breastfed because they follow top feed formula irrespective of viral load, but definitely it is a shared decision making. So if the patient viral load is less, but she prefers to breastfeed, then the baby will fall into this category. Okay, you got it. So now when the baby is to be tested, so the baby is to be tested for RNA PCR within 48 hours or before discharge. Okay, in a non-breastfed groups, and after 2 weeks after the prophylaxis. Okay, the baby will receive the prophylaxis either 2 weeks or 4 weeks. It may be monotherapy or it may be multiple drugs combined therapy. Okay, so you will do 2 weeks after the end of the prophylaxis or 8 weeks after the prophylaxis, and if it is high risk, then it is done at 2 weeks also. So for non-breastfed infants, you will do it 48 hours one test, then at 2 weeks after the PEP, then another at 8 weeks after the PEP. Okay, and if the baby is high risk, then at 2 weeks also it is done. Okay, and final testing of the HIV antibody is done at 18 to 24 months. So non-breastfed infants is very simple. One, you will do within 48 hours. Second, you will give PEP for 2 weeks or 4 weeks, and after the stopping the PEP, after 2 weeks you will do another, you will do at 8 weeks after the stopping the PEP, and then HIV antibody final at 18 to 24 weeks you will do. Okay, but if it is a breastfed infant, in that particular case, you have to do one at 48 hours. Second, always do at 2 weeks. Here 2 weeks is done only if the high risk it is there. Okay, then you will be doing monthly during the duration of the breastfeeding. Once she stops the breastfeeding, then you will do monthly for 2 months. That is 4 weeks and 8 weeks after stopping the breastfeeding, and then you will do HIV antibody test at 18 to 24 weeks. Okay, so for breastfed infants, 48 hours, then another at 2 weeks, then monthly till the duration of the breastfeeding. After stoppage of the breastfeeding, at 4 weeks and 8 weeks, you will carry out the screening by RNA PCR, and final will be at 18 to 24 weeks. Is it clear for the breastfed infants now?
Yes, sir.
Okay, and for non-breastfed infants, within 48 hours. Okay, for low risk and very low risk, 2 weeks after stoppage of the and 8 weeks after stoppage of the PEP. But if it is high risk, then you will carry out at 2 weeks also. That is why you should see the category of the baby and then you select the option. And final is at 18 to 24 weeks. Okay, so that finishes the this particular BHIVA guideline also. Welcome all. Today's class is on bacterial sepsis in pregnancy. This is Green Top guideline number 64A, published in April 2012. We begin with our quote, Master MRCOG with concept-oriented clarity. So bacterial sepsis in pregnancy, this topic is going to be very important from examination point of view. Actually, there are two guidelines. One is a 64A, another is a 64B. Today we will discuss only 64A, but both guidelines are important from the examination point of view. So sepsis in pregnancy, there is a significant increase in the maternal death in the UK because of sepsis. In 2006 and 2008, sepsis became the leading cause of direct maternal deaths in the UK. Group A streptococcal infection caused 13 deaths. Severe sepsis mortality, here please remember the figures of severe sepsis mortality, 20 to 40% mortality rate for severe sepsis with organ dysfunction. Okay, so severe sepsis mortality is 20 to 40%. Okay, and mortality increases to 60% if it is a septic shock develops. So if you are asked about the mortality due to septic shock, it will be 60%. If it is due to the severe sepsis, the mortality is in the range of 20 to 40%. Hope this is very clear to you. This is one of the SPA. Okay. Early recognition and treatment. Studies in non-pregnant population show that early recognition and treatment improves the survival rate. Now there are certain definitions. Sepsis is nothing but the infection plus systemic manifestation of infection. Severe sepsis is sepsis with organ dysfunction or tissue hypoperfusion. Okay, and septic shock is a persistent hypoperfusion despite adequate fluid replacement therapy. So that is a septic shock. In septic shock, there is a persistent hypoperfusion in spite of adequate fluid replacement therapy. Okay, so these are the definition. Now, what are the risk factors for maternal sepsis? These are obesity, then impaired glucose tolerance, impaired immunity or immunosuppressed medications, anemia, vaginal discharge, history of pelvic infection, history of group B streptococcal infection, amniocentesis and other invasive procedures, cervical encerclage, prolonged spontaneous rupture of membrane, group A streptococcal infection in close contacts or family infection, and black or other minority ethnic group origin are at risk of maternal sepsis. Okay, so in the scenario, you look for if these are present and look for then whether it is, are you dealing with the scenario which is related to maternal sepsis. Okay. Now, the most important, it covers this particular guideline. What does it cover? It covers the recognition and management of serious bacterial illness during antenatal and intrapartum periods. Okay, so the current guideline which we are going to discuss will cover antenatal and intrapartum periods. It will exclude the viral, fungal, and other infections. Separate guidelines are there for puerperal or the bacterial sepsis. Okay. Clinical signs suggestive of sepsis. Common symptoms are pyrexia or hypothermia, tachycardia, tachypnea, hypoxia, hypotension, oliguria, impaired consciousness, and failure to respond to the treatment. Not all symptoms may be present, and severity is not always indicated by the presence of symptoms. Monitoring and observation. Record vital signs, that is temperature, pulse, blood pressure, respiratory rate on MEOS chart. Annual training on MEOS chart used for staff taking observations. So this MEOS chart is very, very important. Okay, there is modified early obstetric warning score. Okay, challenges in diagnosis. Sepsis symptoms in pregnancy may be less distinct than in non-pregnant women, and high suspicion is necessary due to variable presentation. Now, what are the specific signs which we need to look for? Genital tract sepsis, there may be severe abdominal pain and tenderness which is not relieved by the analgesia. Then preterm labor, don't treat the preterm labor, always look for some focus of infection. So severe infection may trigger the preterm labor. So if you are dealing with the preterm labor, look for the source of infection. And third, it can be a case of toxic shock syndrome. The symptoms of toxic shock syndrome may include nausea, vomiting, diarrhea, severe pain. This pain may be because of necroticizing fasciitis. This can also be a EMQ. Okay, watery vaginal discharge and generalized rash. Okay, and conjunctival suffusion. If you get these 2-3 things, then your diagnosis will be toxic shock syndrome. So please look for this conjunctival suffusion and watery vaginal discharge, generalized rash, and necroticizing fasciitis or severe pain. Then most probably you are dealing with a diagnosis of toxic shock syndrome, and your option for selection may be toxic shock syndrome. Then what are the clinical features suggestive of sepsis? Okay, fever or rigors, diarrhea or vomiting may indicate exotoxin production or the early toxic shock. Okay, so this diarrhea, vomiting, generally exotoxin production, because of that it is there. The rash, streptococcal maculopapular rash or purpura fulminans is there. Abdominal and pelvic pain and tenderness. Offensive vaginal discharge, smelly suggests anaerobes. Serosanguinous suggests streptococcal infection. Okay, then productive cough and urinary symptoms. So these particular nature of these particular secretions, vaginal discharge also, remember, sometimes they may give this particular thing, the oral sepsis, and look for, they may expect some diagnosis. Serosanguinous suggests streptococcal infection, smelly suggests anaerobes, etc. etc. Then coming to the appropriate investigation for suspected sepsis. What investigations you are going to carry out? You will do the blood culture, serum lactate, imaging studies, and additional samples. MRSA screening is also required, and prompt imaging is required. Now coming to the blood culture. Blood culture is the key investigation, and this is to be done before starting the antibiotics. Antibiotics should not be delayed for microbiology results. You just collect the sample and give the antibiotics. Don't wait for the results to come. Okay, later on the antibiotics can be changed. Then serum lactate. This is also one of the most important thing, and major serum lactate within 6 hours if the maternal sepsis is suspected. This, remember, 6 hours. This is there is a sepsis 6 bundle. Okay, so serum lactate is to be measured within 6 hours if the severe sepsis is suspected, and lactate more than or equal to 4 millimoles per indicates tissue hypoperfusion. This lactate more than 4 or equal, this figure is also very, very important, more than 4. So serum lactate is to be done within 6 hours, and 4 or more level of lactate indicates severe tissue hypoperfusion. Then imaging studies performed promptly to confirm the infection source. Additional samples, obtain blood samples on clinical suspicion, maybe throat swab, urine, depending upon the system involved, you will take the sample. Sample must be obtained before starting the antibiotics, but antibiotics should not be delayed. Okay. Then MRSA screening. If MRSA status is unknown, send a pre-motion nasal swab for rapid screening. Okay. And prompt imaging. Imaging should not be delayed due to pregnancy and may help to identify the infection source for targeted treatment. So just because she is pregnant, don't delay the imaging. Okay. Now there is a surviving sepsis campaign, SSC. Okay, surviving sepsis campaign. So they have given resuscitation bundle. These are the tasks which is to be performed within 6 hours of identifying the severe sepsis. So what are the things which we have to do? One is obtain the blood culture prior to the antibiotic. Second, give IV antibiotics within 1 hour of recognizing the severe sepsis. IV antibiotics should be given within 1 hour of the recognizing or suspicion of the sepsis. You will give within 1 hour. Okay. And serum lactate is to be measured within 6 hours of the suspicion of the severe sepsis. Now, if there is a hypotension and or serum lactate is more than 4, give crystalloids or equivalent with a dose of 20 ml per kg. Okay, so first you give IV antibiotics. First you will send the culture. You will give IV antibiotics. Measure the serum lactate. If the serum lactate level is high, or if the patient is having hypotension, give 20 ml per kg crystalloid. If there is a persistent hypotension and or there is a lactate more than 4, the patient is in shock, then you will add vasopressors. So first give crystalloids. Okay. In spite of that, if there is a hypotension, then add vasopressors, because you are likely to deal with the septic shock now. And maintain mean arterial pressure more than 65. If there is a persistent hypotension, lactate is more than, then you monitor CVP also. So you will add vasopressors. You will try to maintain mean arterial pressure more than 65. You will also maintain the CVP more than 8 millimeters of mercury and achieve central venous oxygen saturation SCVO2 more than 70% or mixed venous oxygen saturation more than 65%. Okay, central venous oxygen saturation should be more than 70% and mixed should be more than 65%. Okay. Now, indications for transfer to the ICU. Okay, what are the indications? Cardiovascular system such as hypertension or raised serum lactate persisting despite fluid resuscitation. We have seen first is a fluid resuscitation. Means once you send the investigations and all, blood culture, serum lactate and all, IV antibiotics given, start with the fluid resuscitation. But in spite of that, there is the patient should be shifted to ICU. Okay. And mainly for the inotrope support. Respiratory such as pulmonary edema, mechanical ventilation, airway protection. For this, the patient requires ICU admission. Renal dialysis, neurological, significantly decreased conscious level, miscellaneous multi-organ failure, uncorrected acidosis, hypothermia. Collaborative care for women in sepsis. It is always a multidisciplinary care which is required. So frequent observations such as regular monitoring with Meo's chart is recommended for early identification. Urgent referral, critical care team involvement for severe or rapidly deteriorating cases. Consultant obstetrician should be involved and expert advice. Consultant microbiologist and infectious disease physician. So never forget when you are dealing with these sepsis, there is a lot important role of consultant microbiologist and infectious disease physician. They should be urgently consulted if serious sepsis is suspected. Okay. So it is always a multidisciplinary team management. Then MEOT chart, okay, used for all maternity inpatients to identify seriously ill pregnant women, helps in referring to critical care and obstetric anesthetic teams based on local guidelines. There has to be goal-directed resuscitation, proven to improve the survival for septic shock patients. Surviving sepsis campaign resuscitation bundle should be started pending ICU transfer. So whatever is this bundle, we have just seen what exactly steps are there. Then patient should be shifted to ICU. Decision made by the critical care team, obstetric consultant, obstetric anesthetist, cardiac output monitoring, ventilatory support, renal support typically require ICU transfer. Common organisms, including hospital, these are the SBS which are asked. Most common is a group A, beta hemolytic streptococcus, and second is a E. coli. These are the common ones. Okay, mixed infections often occur in chorioamnionitis with both gram-positive and gram-negative organisms. Coliform infection associated with urinary sepsis, PPROM, and cercalage. So these things are associated with coliform infection. Okay, so sometimes they will ask you the common infection, but if they are asking with respect to this, then select E. coli. Okay. Then anaerobes, they are less common but include Clostridium perfringens or gas gangrene. This is also SBA they have asked in the past. Okay, so here you have SBA, that is what this slide is important. Okay. Then empirical and specific antimicrobial therapy. Here also there are SBAs on this slide. Broad spectrum antibiotics, IV antibiotics should be administered within 1 hour of the suspected severe sepsis with or without septic shock. Genital tract sepsis, early treatment with high dose broad spectrum IV antibiotics is critical. And empirical therapy, use antibiotic active against gram negative bacteria, the one which prevents exotoxin production from gram positive bacteria, and follow local microbiology policies and narrow treatment once the positive organism is identified. Now what they are talking about, cefuroxime and metronidazole. Okay, previously this cefuroxime has been widely used. Okay, so previously recommended for genital tract sepsis, but cefuroxime is now less used due to the Clostridium difficile risk. Okay, neither it covers MRSA, Pseudomonas, or extended spectrum beta lactamase organisms. So that is why cefuroxime has got these many limitations. So it will not cover MRSA. Pseudomonas and ESBL will also not be covered. Then local guideline, follow hospital guidelines for appropriate antibiotics as resistance patterns vary across the UK. Source control, along with antibiotics, identify and manage the infection source, such as delivering the baby in some cases. Okay, so sometimes you may have to consider the delivery of the baby also. Okay. So antimicrobial choices and limitations of antimicrobials. Again, here there will be SBA. Coamaxclove. What is the issue with the coamaxclove? Necroticizing enterocolitis risk in the neonates. Okay, so coamaxclave is not preferred. Again, it will not cover MRSA, Pseudomonas. Same thing what we have seen with cefuroxime, that also not cover MRSA and Pseudomonas. Here also coamaxclave not covering MRSA, Pseudomonas, plus risk to the baby. Metronidazole will cover only anaerobes. It will not cover gram positive, gram negative. Then Clinda will cover anaerobe, but it covers most streptococci, staphylococci, and it will also cover MRSA, switches of exotoxin production, reducing mortality. It is not nephrotoxic and renally excreted. So clindamycin is covering strepto, staphylococci, that is gram positive. Many MRSAs are covered. It will switch. So this is mainly gram positives are getting covered and non-nephrotoxic and renally excreted. Okay. Then piperacillin and tazobactam, it will cover all, but it will not cover MRSA, and it is renal sparing like aminoglycosides. Okay. Then gentamicin poses no issue in normal renal function. If given regularly, serum levels must be monitored. Single dose 3 to 5 milligram per kg, provided the normal renal function is there. Sometimes they ask you, they will give you the creatinine clearance and they might ask you the dose. Okay. So gentamicin, normal creatinine clearance 3 to 5 milligram per kg can be given. What is the role of IV immunoglobulin in sepsis. So what is the indication? Used for severe invasive streptococcal or staphylococcal infection if other therapies fail. What is the mechanism of action for immunoglobulin? It is immunomodulatory in nature. It neutralizes super antigen effect of exotoxin, inhibits TNF and interleukin production, effective in exotoxic shock like streptococcal or staphylococcal toxic shock syndrome, limited benefit in gram-negative sepsis. This IV immunoglobulin is mainly effective in the exotoxic shock, okay, gram-positive. Contraindications: if the patient has got a congenital immunoglobulin A deficiency, consultation, discuss use in severe sepsis with infectious disease or microbiology expert, available from the blood transfusion department and administered via blood warming device. Then fetal monitoring and delivery consideration. As I told you, sometimes in sepsis we might have to deliver the patient also. Okay, what should be the timing of the birth? Timing of the birth should be decided by the obstetrician and the mode of the delivery, timing of the birth is to be decided by the obstetrician. Consider birth if it is beneficial for the mother, baby, or both. Then preterm delivery, consider antenatal corticosteroids for fetal lung maturity if sepsis is present. Intrapartum care, always continuous electronic fetal monitoring is recommended. We have seen all the indications for continuous electronic fetal heart rate monitoring. Okay, CTG changes, baseline variability or deceleration should prompt reassessment of maternal condition. Anesthesia, avoid epidural or spinal and prefer general anesthesia, typically required for cesarean section. So in sepsis, always if you have multiple options for the delivery, the option with general anesthesia will be preferred. Okay, then fetal risk, intrauterine infection increases the risk of neonatal encephalopathy and cerebral palsy. Preterm delivery, again antenatal corticosteroids can be considered. Then fetal heart monitoring, electronic fetal heart monitoring is crucial even in absence of pyrexia. Delivery decision, maternal instability increases the maternal and fetal mortality, especially if infection source is not intrauterine. Decision should consider severity of the maternal illness, gestational age, and fetal viability. So this is decided by the obstetrician team only. Okay. Now coming to the prophylaxis for neonate, family members, and healthcare workers. Neonate prophylactic antibiotics if the mother has got a group A streptococcal infection. So then baby will receive prophylactic antibiotic. Any close household contacts, warn the contacts to seek medical attention if they develop the symptoms and consider antibiotic prophylaxis for contact. Okay. Then healthcare workers, antibiotic prophylaxis for workers exposed to the respiratory secretions from women with group A streptococcal infection. Suppose mother is diagnosed with group A streptococcal infection and the worker is exposed to respiratory secretions, then antibiotic prophylaxis is indicated. Guideline: follow local or national guidelines for group A streptococcal infection control. Discuss with neonatology colleagues regarding antibiotic prophylaxis for babies born to mothers with sepsis. Okay. Now, infection control consideration. What is the mode of transmission? Group A beta hemolytic streptococcus and MRSA are easily spread by the hands of healthcare workers and close contact in the households. So these are the modes of transmission. Isolation. Women with suspected or diagnosed group A streptococcal sepsis should be isolated in a single room with ensuite facilities and minimize spread to other women. Notifiable infection. Invasive group A streptococcal infections are notifiable. Notify the infection control team and consultant for communicable diseases. Local guidelines: follow the hospital-specific isolation and contact precautions and seek local advice for infectious control colleagues. So that finishes this particular guideline. Thank you.